Excellencies, distinguished guests, dear colleagues, ladies and gentlemen, dear Carl, as Dean of the Faculty of Medicine of the University of Geneva, it is a profound honor to welcome you all today to this important gathering for the global launch of the report of the Johns Hopkins Center for Humanitarian Health and Lancet Commission on Health, Conflict, and Forced Displacement, hosted by our Geneva Center of Humanitarian Studies. The humanitarian system is currently experiencing tremendous internal changes. We are operating in an era of unprecedented strain, trying to cope with a brutal financial crisis, while simultaneously dealing with the large-scale conflicts that test the limit of our collective capacity. The gap between humanitarian needs and available resources has never been wider. At the same time, global shifts are altering the very nature of humanitarian action. Climate change and the rapid emergence of new technologies, such as artificial intelligence, are shaking the very foundations of the humanitarian response. Climate change is rewriting the map of vulnerability, while AI introduces powerful efficiencies alongside complex ethical challenges. Faced with this compounding crisis, minor adjustments are no longer enough. The humanitarian system requires in-depth transformations. We must rethink our models, our funding structure, and our operational models. Here at the University of Geneva, based in Geneva, we do more than just observe the profound shifts reshaping Geneva's health and humanitarian governance. We are active drivers of this transformation. Through our Institute of Global Health, we provide the science and evidence needed to guide policymaking while training the next generation of researchers and practitioners. Leading this charge is our Center of Humanitarian Studies, directed by Professor Carl Lancet, which serves as our premier platform for turning these ambitions into reality. On a more personal note, I'm really happy that members of my research team are also co-authors of this report and show the importance of structures like the Geneva Digital Health Hub, an initiative of the Faculty of Medicine, funded and set up by a collaboration with the Swiss and Development Cooperation Agency and with the World Health Organizations, and trying to provide evidence, evaluation sciences and implementation sciences in the field of digital interventions in health. Today, we are very much pleased that some of the best experts from various settings have joined us. You have given us strategic directions and concrete recommendations needed to guide this evolution. Your diverse expertise is the roadmap we need to build a more resilient future for humanitarian action. Finally, I would like to express our deepest gratitude to the Lancet for this wonderful opportunity, providing this platform for rigorous dialogue, allow us to bridge science, policy, and practice when the world needs it most. Thank you all for your presence, your commitment, and your shared vision. I wish you all a highly productive and inspiring event. Thank you. Thank you. Thank you.
Thank you very much, Antoine. Thank you very much. Now I'm going to welcome Anna and Richard, but before that, how do we start a Lancet Commission? So it could start with a few phone calls with a few like-minded people who said, maybe there's something wrong, and then it probably start time to do something and to use our power as academics to actually reflect and try to provide some guidance. And then we submit this idea to the Lancet and to Richard and Anna, and then and he said, fine, but if you do it, you have to be brave and very bold. If you have nothing to say, just stay home. No need to spend 2.5 years on the top of your work and spend your weekend on that. And I hope, Richard and Anna, that we have achieved that, and that actually these directions are bold and brave enough for you. Dr. Richard Norton and Dr. Anna Matthews, I leave the floor to you. Thank you.
I'm so excited to be at the launch of this report today. And I would like to congratulate the commissioners, in particular, Paul Spiegel and the co-chairs, Carte Blanchett, Esperanza Martinez, and Chichi Undi, but also a huge thank to the reviewers who provided very thorough and constructive comments that really shaped the report, and all my colleagues at the Lancet who ensured we could be here today launching this report. When discussions about this commission started in mid-2023, the world was quite a different place. But at the time, the humanitarian system was already overwhelmed and unfit for purpose. And for too long, aid has been driven by political and economic interests, with few powerful actors setting the agenda, centered around the complex of international humanitarian and development organizations, lacking cooperation, failing to prioritize the dignity and health of affected populations. Previous attempts to correct this have been diluted by power dynamics and fragmented agendas. But amid unprecedented humanitarian needs and recent funding cuts, change is now inevitable. And by shaking the entire humanitarian system, the current crisis creates the conditions to fix it. Destroying it, as many might want, is not an option. 239 million people need humanitarian assistance, and estimates published by the Lancet show that abrupt changes can cost millions of lives. At this important juncture, what this Lancet Commission report provides is a comprehensive argument and a roadmap for a wholesale transformation towards a more just, robust, and sustainable humanitarian system. This was achieved through an integrated scientific analysis of the system's fundamental structures, as well as through commissioners' humility and self-analysis, and a sense of mission so deeply imprinted in their DNA. This was not just an academic exercise. It was centered around the voices of those affected and their realities, anchored in humanity. At the core of this manifesto is the need to invert power and focus on populations, something not limited to humanitarian action and so relevant to discussions around health governance that are ongoing in this moment. As we live through some of the darkest moments in recent history, stuck in what feels like an endless interregnum, a new world can emerge. The moment calls for courage and leadership from countries, particularly middle powers, to come together and support this effort to transform the humanitarian system. Beyond the moral argument for shared humanity, we now live in an interconnected world. And as we know, crises such as climate change, pandemics, war, and migration have no borders. International solidarity serves long-term stability that benefits everyone. And compared to national budgets, the defense financing costs little. Above all, we must not be nostalgic about the past. We should be hopeful about the future and excited about a reformed humanitarian system and aid that confronts power and incentives and that truly prioritizes populations and human health, laying the foundations for pluralism, solidarity, and humanity that transcends humanitarian action. Thank you.
Okay, last introduction before we get on to the real thing. My name is Richard Horton, also from the Lancet. Let me thank Paul, Esperanza, Chichi, and Carl for their absolutely fantastic leadership and all of their team. This is a real tour de force you're going to hear about. Let me also acknowledge and thank Anna for her tremendous leadership and intense commitment on this project. Now, peer review, as you know, is at the center of what any scientific journal does, but it's often misunderstood. Peer review doesn't validate work, it tests it and it challenges it, and it locates that work within a zone of acceptability in the community. So when I read back over the reviewers' comments, let me share some of the words that were used. Urgent, immense ambition, a vast amount of work, remarkable, exceptionally rigorous, courageous, compelling, a masterpiece of analysis, synthesis, and vision. So this was the reception of the commission as we put it through this independent peer review. What is also clear as we began to engage with the Commission's findings and recommendations is that the humanitarian system, and indeed humanitarianism
fundamentally itself is such a deeply contested area and space that, in a sense, provides its own challenge as we try and work through what we understand by the recommendations that we're going to discuss today. And I'd like you to bear in mind, very briefly, 5 thoughts as we run through this morning. The first one is, we're not in a static situation. The nature of humanitarian crises is changing. The protracted violence of civil wars, wars of total annihilation, seemingly legitimized by the international community, the impact of artificial intelligence and technology on weaponry, the weaponization of information. So this commission, one of its challenges is that it's confronting a highly dynamic situation, which makes the afterlife of this commission, which I hope we have a moment to talk about, so important to think about. Second, the conceptual basis of what we mean by humanitarian action is absolutely not agreed. The long-term influence of imperialism, colonialism, and racism is far too little acknowledged in our discussions about humanitarian action. The manipulation of humanitarian principles to camouflage war crimes, even genocide, is now common in our international dialogue. And the terms such as neutrality and independence are utterly misused when clearly humanitarian work can be neither neutral or independent. A third dimension, please consider, is that when sitting in a beautiful hall such as this, in a very peaceful city such as we are, we should be very conscious of the operational realities of humanitarian work, the practical constraints that face an effective humanitarian system. In conflict settings, there is little evidence that impunity will diminish. The violations of international humanitarian law have continued without meaningful consequence. And the humanitarian system itself has become unfit for purpose, quite simply because it's been overwhelmed by external realities. The fourth point is that the great strength of this commission, I think, is the way that it's brought disparate elements together, such as community engagement, governance, local systems, health system capacity financing, brought together into an integrated whole. But the challenge is going to be, and please let's discuss this, the challenge is going to be implementation and feasibility. What are the political pathways that we're going to choose through which the Commission's proposals could be realized? What is the concrete detail of how? We need a political strategy, and I hope we can begin to formulate that political strategy today to translate the Commission's recommendations into reality. And finally, we need to ease the tension between our ambition and that reality, because the truth is that the financing environment for humanitarian work is not encouraging. Agencies such as ICRC, MSF, UNRWA, represented in this room today, continue to deliver life-saving services and meaningful humanitarian action despite this inauspicious environment. So this commission calls for a new era of political will, rightly, and financial capacity, rightly. But what if neither materialize? What is our plan B? It's very likely that we are going to need alternative pathways, transitional models, and resilient strategies to get us through the next very difficult few years. What the Lancet can offer you today and will offer in the future months and years is our long-term commitment to Paul and his team to provide a platform for advocacy, of course, for convening and for further work, to bring the vision of this, if I may say modestly, extraordinary initiative to full realization. Now let's hear from Paul. Thank you very much.
Thank you very much, Richard. Thank you very much, Anna. Thank you very much. The report has just been released today, so you have postcards on your seats, so you can download the report, you can read the report. And then you have seen when you entered, you're going to see that during the break as well, quite a few quotes on the screen. They all come from affected populations, quotes that we have collected during the commission work. And many of the researchers actually did some field work here, and many of them are here, making sure that voices from affected populations can be heard and can be published. They're all in the report as well. So to be able to achieve such a commission, 48 people, you put 48 people, experts, and you put them in a ship. But we didn't go on a cruise, not at all. We were on a roller coaster. Gaza started after we started the commission, and suddenly we had to completely revisit what we wanted to say, or all the principles that of the system based on what we were witnessing in Gaza. Also, our individual lives as well, quite a roller coaster. I didn't know I would do a second PhD in my life, but this commission is probably one of them. And to be able to make sure that everybody is going to keep the right direction, you need a good captain. And Professor Pospiegel was one of them, calm, listening to us, but being firm as well on the direction that we need to have, and making sure that we don't get too excited on some directions, but making sure that it makes a lot of sense. So now I don't want to give the floor to Pospiegel, professor at Johns Hopkins, who is a chair of this commission. And for the first time, you're going to hear about the content of the report in inclusivity here in Geneva and online. Paul, the floor is yours.
Thank you all. Let me make sure that I can move the slides. Yes. Okay. Thank you. Richard, when I was reading the reviews, I don't remember the word masterpiece. I remember I don't agree with this. Can you change this comment? But nice to know. Nice to know it was there. Thank you, everyone. And thanks to particularly the co-chairs, the commissioners, next-gen scholars, which we really didn't talk about, but each commissioner chose a younger generation to really really see what they can do, how they see the world, which is quite different than some of us, and also to expose them to a commission. And so thanks to all of that. Thank you to the Lancet. Thank you to the advisory committee. It's been quite a journey. So I'm going to start and just make sure I'm on the correct slide. I am. It's a privilege to be here at the campus Biotech with the Institute of Global Health to launch this CHH Lancet Commission. Our title is Health in a World of Crisis and Impunity. And that title is deliberate, and it has two things at once: the crisis itself and the failure to enforce the protections that we already have. So Health in a World of Crisis and Impunity is not a neutral title. It's not meant to be a neutral title. It's a problem that we must face. So I think many of you in the room are safe. Firstly, it feels like we're at a old friends and colleagues getting together. It's wonderful to see so many of you here. I think you know many of these numbers, but between 21 and 24, conflict-related deaths have nearly doubled. In 2026, 239 people need humanitarian help, yet only 87 million, or 36%, are actually prioritized. So this is rationing by design. $23 billion would cover the world's most life-threatening humanitarian needs, and that's less than 1% of the global military spending. The money is there. What's missing clearly is the political will. So a system meant to respond has been gutted at exactly the time where the need has peaked. So this is the long view. In 1980, forced displacement was a relatively small phenomenon compared to what it is now. Today, more than 123 million people are forcibly displaced, the highest number ever recorded. And look at after 2011. Syria, Yemen, South Sudan, Tigray, Ukraine, Sudan, Gaza, just to name a few. Each rise in these numbers is a political failure that become someone's permanent reality. Displacement now lasts decades, and a system that was built for short emergencies is being asked to manage what are, in practice, life sentences. So these are some numbers that actually are not published from Security Insight. Attacks on health workers, attacks on hospitals and clinics, attacks on supply chains and patient transport, all are rising fast and relentlessly. In 2024 alone, Insecurity Insight has reported that there have been 3,663 reported attacks on healthcare and their infrastructure. That's 18% more than 2023 and 58% more than 2020. And we all know that these attacks, these numbers are far higher than what is being reported. Attacking hospitals is not a tactic of war. It's against the law. Condemnation without consequences is sadly now become the norm, and it is not acceptable. And here's the picture of who actually controls the response. The grand bargain promised that 25% of humanitarian funding would go to local actors by 2020. Nearly a decade later, we're still far from that target. So in 2024, 95.7% of direct, not indirect, but direct humanitarian funding went first to international actors. Only 4.3% went directly to local and national actors. This is not a technical failure. It's a failure in how power, trust, and resources are shared. Now, this is something interesting that I think is important. This is how the equity picture is over the last 15 years. Between 2009 and 2024, the 10 largest humanitarian crises have produced, on average, between 55% to 75% of all the world's internally displaced persons, and 64 to 84% of all refugees. So just these 10, and they've changed over time, but not a huge amount. You have your usual suspects for now decades. Yet in these same crises received only 29 to 54% of the funding. And the gap, although relatively steady over 15 years, has seen some changes. In some years, it was more than 40 percentage points difference. So again, this is structural. This is not anecdotal. The need and the funding is not going where the need is. And behind every data statistic on these slides is a person. And this commission worked hard to listen to them. So these are images from a photo voice study with displaced Syrian youth in Turkey. On the top right, 12 years after displacement, a young person is still living in the shadow of an earthquake. In the middle, isolation in a school where she has no one. At the bottom, a pot of food brought by a Turkish neighbor when her mother was sick. Solidarity captured in a single object. We wanted the voices of the people that the system is meant to serve to shape both the diagnosis and the recommendations. So as Carl mentioned, we've been at this now for over 2 years. It involved 21 commissioners, 21 next generation scholars, which is an incredibly diverse group, many of whom are here today and are watching online. Many of them have lived experience. You know, we were very, very careful and cognizant of who we chose. So many have actually lived through conflict and displacement and currently still are. We had an advisory group of 29 experts, donors, UN agencies, other multilateral organizations, and international, regional, and national NGOs. The commission was shaped by 533 affected people and humanitarian workers who we interviewed across 12 countries. We had 13 thematic working groups and multidisciplinary expert reviews, which strengthened the analysis throughout. So our ambition is actually structural. We want to rethink the strategies, governance, and delivery of humanitarian help. And we want to amplify the voices of those that the system is meant to serve. We realized early on, this is not a typical Lancet commission. I think many of you would have thought, we'll look at health, we'll look at NCDs, infectious disease, outbreaks, etc. But what we realized early on was that if humanitarian health is going to save more lives than it should be and be more effective, the system itself has to change. And so we focused on the system, and then we moved towards health. And each time we examined a part of the system, we then brought it down to health. So this is not another call to do better. It's a call to do differently and to do so now. So here's our conceptual framework. To organize our analysis, we built a framework, and I'll walk you through 3 quick slides of this. So understandably, and I think appropriately, we anchor the response in the people themselves, individuals, households, communities, and service providers. We then look at recognized de facto authorities, and you will see consistently, we don't talk solely of governments. We talk about authorities. So many conflicts, we have the territory is divided between state and non-state actors. So if we just deal with governments, we are not going to be successful, clearly. So we talk about authorities. And at the heart of the framework is the person, not the agency or organization. We then move towards humanitarian development. There's a lot of discussion in the Commission on the Humanitarian Development Peace Nexus. And we also look at the ecological environment. And these are not separate worlds. They really must be examined together. On the left, we have the drivers of crises: conflict and insecurity, forced displacement, public health emergencies, climate-induced events. And you will see, as opposed to bringing out climate and climate change, climate emergency, it is diffused throughout, as is accountability. We then put into 3 crisis typologies, and we can discuss this. I'm curious, we all are curious to get your feedback on this. But we have new acute crises. We have acute on protracted and protracted. And obviously the latter 2 are by far the largest. But when we have a new acute crisis, it's a little bit different in how we may respond. And finally, all of this affects the people, what we call humanitarian health. We then look at strategic drivers. Across all of this, we have international law. We had, the commissioners, the next gen, were quite diverse, as we said. We had David Cantor's here with us, Esperanza Martinez. We had experts in international law, in humanitarian principles, governance, financing, and health systems. We did have a 6th one, which was technology, including AI, but the report was just too big. So we put technology and AI into health, but it is obviously a massive, massive issue. And each of these are levers, and every recommendation we make pulls for at least one or more of them. Finally, we have 6 themes running across what we propose: social determinants of health, populations and conditions of vulnerability, community engagement and accountability to affected populations, data and evidence, and then technology, including AI, as well as localization. And you'll hear a lot about localization. So these are not chapters in the report. They're just threads throughout every recommendation that follows. So now we'll go through the 4 large recommendations. So our first recommendation is to invert the power. Affected communities and local actors we know are closest to the need. They act fastest. They understand the language and the culture. They're most accountable to the people that they serve. They are the people. And yet they remain at the edge of decisions about their own crises. A health official in DRC told us that decisions are often made in the capital or internationally, far from local realities, which leads to delays. This is not a flaw at the edges. This is the system as it has been designed. Success cannot be measured by whether communities were consulted. It must be measured by whether they controlled priorities, resources, and accountability. So here are some examples. We have numerous recommendations or sub-recommendations under the large recommendations, but these are the large ones. So first one is the crisis typology that I mentioned, to think about this in new acute, acute on protracted, and protracted. We said different crises need different responses. An acute emergency cannot be managed in the same way as a 20-year-old conflict. You know, I as an aside, sadly, but I started with Médecins Sans Frontières in 1992 in Kakuma refugee camp. We put it together. It didn't exist. All the Lost Boys were coming over. That camp, as many of you know, is still there. It's larger than it has been. And we can't think of that camp and how we provide assistance and health in the same way as what's happening in Ukraine or in Gaza. So second, we want to make subsidiarity the default. Decisions should be made as close as possible to people affected by those who have legitimate, capable, and trusted, by those who are legitimate, capable, and trusted locally. The question is not which international agency leads. It is who is the closest to the crisis, best placed to lead. International leadership should be the exception, time limited, and linked to clear handover benchmarks. Safeguards also, though, must ensure that power shifts to the communities are not simply to the local elites. Third, we need to simplify the architecture. Today's system is too fragmented, too competitive, and too slow. 10 years ago, as of July 1st, I left UNHCR and to Johns Hopkins, and at that time, I wrote a Lancet article that was called "The Humanitarian System is Not Just Broke, but Broken." And this, I think, was really a genesis of a lot of the commission. I went back to read that, and sadly, it's a decade ago, many of the same issues still are here. So there are too many agencies, too many UN and international NGOs that respond to acute emergencies. They compete for the same mandates, resources, and visibility. So we would recommend creating one unified UN agency that is operational, that's leaner, that's integrated across all of the UN agencies, and that is accountable. We also will go into more detail, and we can discuss this, but we recommend replacing the Custer system and the refugee coordination model with a fit-for-purpose incident management system, particularly in acute settings. And I was on a call recently for Ebola, the current outbreak, and it was a very, very well-run meeting using the incident management system. So invert the power is not a slogan. It has to become the operating default. So decisions, resources, and accountability move closer to affected populations. So briefly on this decision matrix, where we turn subsidiarity into a practical tool. So it asks 4 sequential questions. First, what do communities define as their priorities, and who do they trust? Secondly, who has authority, legitimacy, and accountability to protect people? And we're talking here about authorities, governments, non-state actors. Third, who is already delivering care? Let's look at the local NGOs, faith-based providers, private providers, informal systems, and national institutions. And where are the gaps? Then we move to 3B. Only then should international actors enter, and only to fill a clearly demonstrated time-limited gap, and as we said, with a handover benchmarks from day one. Fourth, can the health system actually hold, adapt, and recover over time? So external leadership should be the exception, not the norm, and it must always have a clock on it. The second recommendation is end impunity. Enforcement of international law is selective at best. Accountability is absent, and civilians and health workers pay the price. A health official in Burkina Faso described the impossible position medical workers face. If I treat a member of an armed group responsible for killing my brothers, it tests my patriotism. If the government finds out, I could face repercussions. Yet if I report it, I risk being seen as an enemy by the armed groups, which could endanger my life. An impossible situation. I think one of the main conclusions of the commission is that the laws, IHL, refugee law, human rights law, they exist. They could be improved, but they're adequate. They are designed to protect civilians, patients, and healthcare workers. In today's geopolitical climate, now's not the time to revisit those laws. The core problem is non-compliance without consequences. Security Council Resolution 2286, passed in 2016. It was just one of our colleagues, Len Rubenstein and others, spoke at the UN Security Council 2 weeks ago on this. It was meant to protect healthcare in conflict. Now, a decade later, follow-up's limited, accountability remains weak, and impunity persists. So an attack on a hospital should trigger consequences, not another statement of concern. Here are some examples of some of the key actions. First, create a health protection alliance, and this has been discussed. A standard platform of states, UN entities, and NGOs, amongst others, that act in a systematic way when health protections are violated. The response must be diplomatic, legal, political, and operational, not another cycle of statements of concern. Second, and this will get some juices flowing, I imagine. Reaffirm when humanitarian principles are which humanitarian principles are sacrosanct. Humanity and impartiality. They are the non-negotiable foundations of humanitarian action. They're relief-based on need without adverse distinction. Neutrality and independence, they remain essential, but they are subsidiary to humanity and impartiality. They really are operational principles, and even when they were written as secondary to, although this can be discussed, impartiality and humanity. They are not legal preconditions for protection under IHL. So we are stating that they are very important in neutrality and independence, but it really depends on an organization's mandate, the context, and they should not be used and penalized if you have national NGOs or local NGOs that are not neutral. They shouldn't be used as a way not to provide funding to them. And then we suggest, given the contemporary crisis, 3 new humanitarian principles because of what has happened in the past and where we are going. Do no harm, solidarity, and accountability. Recommendation 3 of 4, fix the money. Humanitarian financing is still short-term, too earmarked, too donor-driven, and too shaped by foreign policy. A local NGO field coordinator in Turkey told us, this is a field largely shaped by donors. We do whatever the donors ask us to do. If a donor says psychological support will not be provided, NGOs generally do not reject this. That's the problem. Funding decisions often determine what counts as need instead of need determining where the funding goes. Humanitarian financing, as we've seen now, we're in a unique time, has increasingly become a foreign policy instrument. Bilateral and interest-aligned arrangements are expanding and becoming transactional, while multilateral humanitarian financing is being cut. Humanitarian aid should follow needs, not politics. So here are some examples. First, and I believe the appetite for this may not, we're looking at recommendations that can be done shorter term, medium and long term, and we're trying to take into account, the politics and the powers that are at play currently. But we would suggest creating an independent, multi-layered pooled humanitarian fund with governance separate from UN agencies and bilateral donors. The allocations will be based on assessed need and equity, not institutional mandates, donor preferences, or visibility. And it could be modeled on, but it would have to be different, but modeled on public-private partnerships. We've looked at the Global Fund to fight AIDS, tuberculosis, and malaria as an example that could be modified and changed. Second, I think most people agree on this, is to expand cash-based assistance. The evidence is strong. Cash gives people agency, strengthens local economies, and is often more efficient. And cash, I think we all most know, but not everyone, I keep on hearing it. Cash is not uniquely risky. It's not uniquely fungible. In-kind assistance also is constantly diverted. The issue is not the modality. It's the targeting, it's the monitoring, and it's the accountability. And third, and this one could be done actually relatively quickly, we believe, integrate humanitarian financing with national health insurance and social protection systems, particularly in these long-term protracted settings. We all know the parallel systems are costly, duplicative, and often exclude displaced people from the systems that in many cases they're entitled to use. And fourth, use innovative financing tools. This includes responsible private sector engagement, anticipatory financing, blended finance, disaster risk insurance, and public-private partnerships. It's been discussed for a while. It's more complicated than in natural disasters, but we have met with various private sector groups, and it is possible for us to use innovative financing in different ways during acute and protracted settings. It just needs to be modified for conflict and affected populations where the risks are slightly different and harder to predict. And finally, our fourth recommendation is uphold health for all. Universal health coverage is one of the greatest public health commitments of this century. But crisis-affected and displaced populations have too often been treated as a humanitarian carve-out, managed through parallel systems instead of being included in this universal coverage. Parallel systems often become permanent obligations. They're expensive, they duplicate national capacity, and they leave host populations behind. A refugee in Azraq camp in Jordan told us, There are many Syrian refugees in the camps who are in medical fields, nurses, doctors, pharmacists, dentists, and lab techs. If they were given professional practice licenses, they could work with the community and help improve services. This is something small but hugely important. And I think many of us are aware in Turkey, they did give provisional licenses to Syrian health professionals. But not doing this is a policy failure, and it really can be fixed very quickly. War does not suspend the right to health. It makes it more urgent. So here are some examples of key actions. First, make the right to health the test for every decision. Service delivery, coordination, transition should all be judged by one question. Does this expand equitable access for those most in need? Women, children, older adults, people with disabilities. They must be prioritized and not left to the margins. Second, ensure continuity of care and connected to national systems. We've talked about this, and previously at UNHCR, there were, and still are, have been arguing for a long time and advocating for refugees to be put into national health systems. It can be done. It's been done. So trauma care, safe delivery, vaccination, mental health, all of these cannot wait for the crisis to end. Humanitarian health services should align with national health systems from the start when feasible. We don't pretend this is a one-size-fits-all. It's a huge spectrum. Sometimes it's not going to be possible, like in places like South Sudan. But in many of those 10 major crises that we talked about that constitute a significant majority of refugees and displaced persons, it can be done, and it could even be done now. Third, treat attacks on healthcare as crimes, not tactics of war. Protecting hospitals, clinics, ambulances, patients, and health workers. It's a shared obligation across states, non-state actors, and the humanitarian system. Fourth, build health systems for climate shocks and responsible technology. Conflict and climate, we all know, right? It is now, they're not separate. They're together now, and it's only going to be exacerbating. But we've just been doing some studies in Iraq and Mali, and it's clear that the planning is inadequate at this point for what is already on the ground and what is coming. Technology, particularly AI, has huge potential, huge, I think, but only if it's used with safeguards for equity, data protection, and human oversight. Technology must serve the communities and not extract from them. So, in summary, our diagnosis is pretty clear. Incremental reform is not just inadequate. At this point, it's futile and it's dangerous. It gives cover to a system organized around donor control, not around lives. However, the current extremely difficult and dispiriting circumstances, and that's just me being political, that we find ourselves, or apolitical, that we find ourselves in now also create a rare opening. The humanitarian reset, UN80, the ACRA reset, they're all happening at once. And for the first time in decades, the system actually may be unstable enough for true change to really happen. The question is whether we use the moment to protect the status quo or to build something better. A health professional in Syria told us the real issue is that some donors not only expect you to remain neutral, but also threaten to suspend your funding if you show any perceived bias towards the victims. This is the system that we currently have. The 533 lived experience voices that shape this report are not waiting for another reform discussion. They're waiting for protection, accountability, and a system that treats them as equal actors. So this commission is not only a diagnosis, it's a demand for transformation, and we hope a blueprint for action. We have numerous policy briefs that I believe are now live on the CHH Lancet Commission report. So what we're trying to do is to provide, and these are just snippets of what the report could mean for various groups. So for affected populations, for example, claim your care, claim rights, data control, and accountability. For local and national NGOs, assert leadership, demand equitable partnerships, and real cost recovery, not just doing the work, but also indirect costs. UN and multilateral agencies, slim down, improve coordination, stop competing, and let go of power. Donors pool funds through predictable multi-year and depoliticized funding. And academic and research institutes continue to generate evidence, shape policy, guide public discourse. So the full, That's not happening. The full report is published today in the Lancet. There should be a QR code on the screen in the next one, but it exists. So you will have now, it's there. It is open access. That was one of our questions for the Lancet. Are all these commissions open access? But this one is open access because clearly everyone in low and middle income countries in fragile and conflict affected places need access to this report, and the Lancet has done that. So I'll close with the voice of a senior NGO staff member again in Turkey. After addressing immediate needs, the momentum waned. Promises were made, but once the initial phases ended, support diminished, leaving people feeling abandoned. Our job, every one of us in this room, is to make sure that this time the momentum does not fade. This could be a once-in-a-generation moment to actually transform humanitarian assistance, humanitarian health, and we must seize it together. Thank you very much.